Okay, fine. Thank you. Hi guys, welcome to the session where we just dissect the paper that was conducted recently. We'll look at the close options that actually came in the paper. The paper, I would say, would be moderate to tough. Uh, Rather, I'll say more on the tougher side. The options were pretty close, but that is how they have been conducting the paper in the recent couple of sessions. So we take it on the chin and we move on to the first question. This was regarding inferior wall myocardial infarction. I think it's becoming clear at the moment. This is a patient 58 years of age. Maybe the age may not be matching. The ECG may not be very exact, but what is present in the patient or what was given was ST segment changes in lead number 2-3 AVF, which is a standard feature of inferior wall myocardial infarction. Now, whenever there's an inferior wall myocardial infarction, the right ventricle of the patient will not be working properly. And because of this, the blood supply to the lungs will also be less. This explains the fact that why there is a hypotension present in these patients. And primarily the question said, what is the first management that would be done in this patient? We will not give nitroglycerin because nitroglycerin is contraindicated if the systolic BP of the patient is less than 90/60 millimeters of mercury. In fact, what I've highlighted always is that we do not give IV fluids in any type of MI. The only type of MI where we give IV fluids to a patient is inferior wall myocardial infarction. So in this particular case, I will not be comfortable giving diuretics, nitroglycerin to the patient primarily because the blood pressure is already low. And why I will not be giving vasopressors for the person is because that will put more stress on the heart. So what needs to be done for this person with hypotension at the moment is give a fluid challenge of 500 ml. This will stretch the right ventricle and will improve the contractility of the right ventricle. We are trying to use Frank-Starling law. So the correct answer to the current question on the screen is that we'll be giving normal saline for management. And I repeat my statement, we don't give IV fluids to any other type of MI because most of the time it is an anterable MI, there's a pulmonary edema, but this would not be having pulmonary edema. Why? Because right ventricle is failing and we don't have pulmonary edema as a feature of right ventricular failure. So I think we are sorted for the first one. Let's move on to the second one. Nitroglycerin, yeah, nitroglycerin will be giving in left ventricle failure. So you are spot on for that. Let me just cut down on the, yeah. Okay. So moving to the next one, this was a middle-aged male. He was having this effort intolerance, awareness of forceful heartbeats over the last few months. And then he was mentioning about these very classical bounding pulsations in the neck of the patient, which we tend to call as dancing carotids. And along with that, there is also Quincke's sign because there was mention of that careful inspection of the nail beds revealing rhythmic pulsatile blanching synchronous with cardiac cycle. So you will notice that the paper prior to this one and even in this one, they had asked about aortic regurgitation. Traditionally, whenever they ask about aortic regurgitation, it's going to be Austen-Flint murmur. This time they just mediated or they twisted the question in a sense that they mentioned regarding that pulsations in the neck along with that pulsations or pulsatile nail beds in a person. That's because of the regurgitation of blood back into the heart of this patient, and aortic regurgitation will result in development of a early diastolic murmur. So the correct answer in this patient is B. I mean, we'll not have a systolic murmur anyway. And late diastolic murmur is what we usually get with mitral stenosis. So it is just that twisted format and like that pump. What is that pulsations of the neck? That is not the jugular pulsations that he's talking about. He's talking about what is called as dancing carotids. Like we read about, whenever I describe aortic stenosis, I always say that there is a carotid thrill and then there's a dancing carotid of aortic regurgitation. And the second thing is the pulsations in the nail bed of the person, which we need to pick up. And therefore the answer in this case is because the blood will be leaking in the early part of diastole. So a early diastolic murmur would be present in this patient. The answer to the current question would be option number B. Okay. Okay, moving to the next one, there is a pulse tracing which is given in this case, and the pulse tracing is a twice beating pulse in the phase of systole. Now, normally we read about twice beating pulse in both systole and diastole, that is called as a dichrotic pulse, which is seen in dilated cardiomyopathy. This time the pulse was having two peaks in the systole. So the word I can use for this is like pulsus bispherians, or I can also say, like you can argue, it can be collapsing pulse as well. But then the point is that if there is two peaks present, that means that the blood is going back in the heart. And how will the blood go back in the heart of a person? There must be some problem at the level of the aortic valve of the patient. So that is why, like in this particular question, I'm answering as option number B. The rationale I'll give once again for this person why I'm marking as B is because what it is showing is, first, blood is going out of the heart. So that is understandable. But then blood never comes back in the heart now. So there is a collapse of the pulse, that what you can see at the moment. That's because, see, ultimately the momentum blood will carry the blood forward. This part, this is the notch, no, this is normal. This is called as dicrotic notch. That is due to closure of the aortic and the pulmonic valves. But the point is, like, the blood is coming back in the heart. So that's why, like, this pulse representation is shown here. That's a problem with respect to the aortic valve of a patient. So cardiology, as they always say, like, why in, like, I start with cardiology, or like why the first video lectures are those of cardiovascular system, is because they put up questions from there. Okay, so for the next question, interesting one, he had mentioned ejection fraction, I think, of 38%. That is what one of my students told me. There was an ECG also given, लेकिन आपको ECG देखने का जरूरत ही नहीं था ना, because if you are having a patient who's having a loud opening snap, that's what I even said in the last few like sessions, you know, that every time you read a loud opening snap with a mid diastolic murmur, then you have to think in terms of mitral stenosis in a person. And what the ECG he's trying to probably show is that the left atria of the patient would be distended, and because the left atria will be dilated, that is why in these patients in the ECG, the P wave will be showing is a P mitral. Now, even if you're not able to pick up that P mitral, chalega. I mean, who cares, man, that you're not able to pick up P mitral in a question? If he wants to give that ECG in a valvular question, his wish. But that is just to increase the length of the question. What I think is that, like, because the length of the question was approximately 4 lines to 5 lines, so it causes unnecessary pressure. But like I've always said, you need to pick up those words in a question, and your eyes start going to the right answer with practice. The message for this particular question is, one, the word is loud opening snap with a mid diastolic murmur, one, and second, like, there would be a structural dilation of the left atria, which explains why the answer in this case would be a critical mitral stenosis, which is usually less than 1.5 square centimeter and will go in for a percutaneous mitral balloon valvotomy. Yeah, obviously the stem I cannot replicate because you gave the paper. I did not give the paper, right? So obviously, like, by the time you and me will talk, the language will change. The total, I would say, English is gonna change, because this is not in our mother tongue, no? So when you and me are communicating in English, there would obviously be not the exact words that would be used. So yep. I mean, do comment in the chat box if you are having any language available. I mean, that would be cool if you can pick up some keywords which you think are relevant. But otherwise, like, that gist of the question or the crux of the question is what we're trying to focus upon. Okay, guys. So the next one was having a elevated blood pressure in a patient with hypokalemic alkalosis. This I would rate as the easy one. I mean, the easy pickup. Hypokalemic alkalosis we read only with 2 times with alphabet C, right? Cushing syndrome and Conn syndrome in a patient, because pheochromocytoma, you get that PhD manifestations, that's ruled out. In Lidl is like a differential diagnosis of Conn syndrome in a patient. But then considering, like, we'll talk about more common diagnosis at the moment. So we'll talk about from the hormone perspective, Conn syndrome, and carcinoid will be having those flushing episodes present, which is why the it goes out of the window. I mean, two things out of the window are carcinoid and pheochromocytoma. So the only thing that we can think is Lidl versus Cons. And Lidl is something which is very, very rare. And then more importantly, like, there's a channel defect that is present. And for differentiation, I would be needing a aldosterone-renin ratio. I'll be needing an imaging modality. So since they are not given, I'll rely on a more common diagnosis in this particular patient. Okay, yeah, sodium can be normal. Yes, that's the point, man. Sodium is normal. That was a very interesting observation. And this was actually the concept that was asked in last time's INI-CET exam, that in Conn syndrome, sodium is normal because pani bhi aa jata hai na, because water is gonna come in, the salt is also there, the water is also so there. So they are gonna dilute, and therefore sodium is normal in the patient. So that helps me identify, and that goes rather in favor of Conn syndrome in a patient. Okay. Then is that inevitable question on multiple endocrine neoplasia. And he put up a question on MEN syndrome, that is multiple endocrine neoplasia. Like, there was mention of medullary carcinoma thyroid. So there can be only two possibilities. Either it will be like MEN2 or MEN3. Now, obviously, you know that MEN2A is called as 2 and MEN2B is called as MEN3. So we just have to look for RET gene mutations in this case, that is RET 618 is what I'm trying to look for in this particular patient. The RET, I think, was given twice, one with respect to MEN1 and second for MEN2. but then we don't have a medullary carcinoma thyroid with respect to the medullary. I mean, we don't have medullary carcinoma thyroid. The mnemonic is PPM, triple P, so no point of discussing those mnemonics again. But yeah, the red proton oncogene is the one sitting on chromosome 10 is the reason why there would be like a familial basis for pheochromocytoma. There would be family history of a parathyroid adenoma and then medullary carcinoma thyroid. Then was this very interesting question with respect to raised ICP in a person. There was bradycardia, hypertension, posturing. So standard, I mean, there's a road traffic accident, then he's given features of raised ICP. And then the debate is only with respect to Cheyne-Stokes breathing or whether it's going to be Biot's breathing. Now, if you listen to my input in a live class or whether in a recorded video, like I always begin by saying first there is Cheyne-Stokes and then there is a Biot's breathing. And Biot is going to be asymmetrical. It's going to be a irregular breathing. Like there would be hypo, hyper, like there's no pattern present. Unlike if there's a graph which will be going like this, where there's a hypoventilation apnea, then you notice there's an increment followed by like hypoventilation apnea. So there has to be like that pattern of hypo and anapnea in contrast to a irregular respiration. So if it's a irregular respiration, that is what most people give me a feedback that there was no fixed pattern that was present. I think it was a hand-drawn diagram in this one. So for these circumstances, like it's a irregular breathing. And the moment I say irregular breathing, just like you guys are comfortable with irregular pulse is a feature of atrial fibrillation. Irregular breathing is Biot's breathing. And first we have Cheyne-Stokes, then we have Biot's breathing. And because the guy is having posturing, I think that was another hint towards the fact that he's deteriorating even further. And the later part of Cheyne-Stokes is where the Biot's breathing would be present. So we are sorted for the current one on the agenda. Next one talks about this lady. She's having that dry eyes, dry mouth kind of a presentation given with joint involvement as well. You know that rheumatoid arthritis can coexist with any autoimmune disorder. So I don't need to worry about it. But the long stem told me two things. The dryness was like very highlighted by use of artificial tears, drinking water while like swallowing food. So everything points towards Sjögren syndrome. And I think there were two questions. One was with respect to that butterfly rash of SLE with the sparing of the nasolabial folds, which I've not included at the moment because I think the dermatologist has spoken about it. But yeah, I decided to incorporate the one which has not been taken care of, where there can be small joint involvement in a patient with respect to Sjögren syndrome. So at the moment, the main message would be like Sjögren is diagnosed with the help of a labial biopsy, minor salivary gland biopsy with antibodies like ROLA is the word that we can use for it, RO1, and then is anti-RO and LA antibodies. Then comes that question which is given right in the end with respect to rheumat, where he mentioned regarding the involvement of the pancreas of the patient. So initially, like I thought they put up a standard question on malabsorption syndrome. So I was listening to my students talking about like, vague abdominal discomfort, diarrhea, weight loss. So I thought it's like a malabsorption syndrome. But then the word that crept up in the chat was sausage-shaped appearance of the pancreas of a person. Guys, that's a very characteristic feature that is seen with immunoglobulin G4 disease. And in fact, he has himself mentioned no immunoglobulin G4 levels are elevated in a patient. And this condition basically mimics a malignancy. Now, because this mimics a malignancy, it could be a root shock to a person when you tell him, I suspect you have a tumor, and turns out we are having a condition that will respond to steroids in this patient. So immunoglobulin G4 disease, because of the sausage-shaped pancreas, is the main reason why we'll be answering this patient with steroids. Because when I listened to the initial part of the discussion, my mind was like, okay, man, this is going to be pancreatic enzyme supplements. Probably he's talking about chronic pancreatitis. But instead of chain of lakes appearance or damage to the pancreas, damaged ducts, it was like that sausage pancreas, which was the keyword that helped us in analyzing this particular question. Okay guys, a very interesting one. There is breathlessness and cough for a couple of years. It's a female, right? I would like your inputs. Was it a female? Was it a male? It will not change much, but yeah, just wanted to know. And then he had mentioned smoking history of like approximately 30 years. There's no history of atopy. The pulmonary function test post-testing shows a timed vital capacity of less than 0.7 with an increment of 18%. So the first thing that I'll think is because there's an increment of 18%, it should be asthma in a person. But then the point to be understood is that why should FEV1, FVC ratio then remain less than 0.7. It should also tend to become normalized. It should become more than 0.7, because if you are having a FEV1 increment of 18%, then there should be a concomitant increase in the value of FEV1, FVC as well. So point against asthma is like, old age patient. That's why I asked like old female, 60 years of age. So it's unlikely, like, there has to be, asthma is a disorder which might be having onset since childhood. Yes, it can occur in adults also. I don't dispute that. But then there are frequent exacerbations, repeated hospitalizations in a person. So considering the kind of information that is given in this question is obviously not interstitial lung disease, and this is even not bronchial asthma. Why I'm not saying bronchial asthma? Because everything that is given in even the chest x-ray of the patient shows flattening of the diaphragm. There's a tubular heart that is shown. That gives me two possibilities. Either this question, there's a tubular heart because there is going to be expanded lungs which are going to be covering the heart of this patient. So the message that I want to give is that there are only two options left: emphysema and asthma COPD overlap syndrome. Let's look at what most guys have answered in this particular patient. They have given 220. Could you just comment with respect to the 220? Yeah, ABG, we are just coming up. No, the ABG questions are compensated, decompensated, like pretty straightforward ones that don't require too much of effort. We'll just discuss them in few minutes from now. Yes, guys. Okay. So I'm getting an answer as a asthma COPD overlap syndrome in a patient. No, guys, this is not an asthma and a COPD overlap syndrome in a person. Why? Because the X-ray of this patient is predominantly pointing towards the flattening of the diaphragm, a tubular heart that goes in favor of COPD primarily. And then more importantly, like if there was any DLCO, they mentioned emphysema in the question also. Okay, fine. There was emphysema mentioned in the question. Fine, got it. And in the options, okay, tracheal inflammation. Fine. Okay, there wasn't a flattening of the diaphragm. Okay, fine. I get your point, guys. Considering the fact that there is like, we'll have to rephrase the language of the question, but then we go with the ACO, that is a asthma COPD overlap at the moment, the way the question is being mentioned there. And even if there is no flattening of the diaphragm, like I'm okay with it. Like, there's no flattening of the diaphragm, that's okay. There's no tubular heart, I'm still okay with it. But yeah, I mean, considering that if there is recurrent attacks of hospitalizations present in this case, then we'll go with ACO, that is a asthma COPD overlap for this. So the answer should go as option number A, and emphysema separately was not in the options. Do let me know there was any DLCO values in a question. DLCO, diffusion capacity of the lung for carbon monoxide. Yeah, there is no DLCO given. So fine, guys, we will say that this would be, we'll go with asthma COPD overlap, though I would like to do a DLCO to be able to confirm the diagnosis of this patient. Help me with option number B for this patient. Help me with option number B for this question. ILD is ruled out, asthma is ruled out, that is okay. Asthma COPD overlap because of the findings which are present, cigarette smoking and then the FEV1 increment present. There might be repeated exacerbations also present. Help me with option number B, guys. Yeah, emphysema was in the question. Fine, I got it. So this option is going to be like COPD, and I have to differentiate between COPD and asthma COPD overlap. Okay, guys, so I'll go with A as of now, considering the language. But yep, if there is mention of atopy, if there is mention of any hospitalizations, then we will have to go with option number A for this question. Okay. Fine, guys. Moving to the next one, that would be a ABG based question where you can notice the pH is less, the bicarbonate is less, and all the three arrows are going down, down, down. I don't think so. Like I even need to explain this question. You guys would have grabbed that opportunity that if all the three arrows are going down, then we'll say partially compensated metabolic acidosis. I've already explained that rules to you. So in this particular case, even the Winter's formula is getting satisfied. So we'll say metabolic acidosis with compensatory respiratory alkalosis for this patient. So I think this was one of the easier ones where you did not have to like rack your brains there. Any question on CT chest for pulmonary embolism? Quick comments with respect to? Great, guys. If they were same as what we discussed in marathon, then it's cool, right? If we are able to score even 3 out of 4, that's like a good strike rate. Any CT chest where pulmonary embolism was mentioned. Yeah, ABG analysis are easy ones guys. ये तो मतलब बच्चों वाला खेल है, right? चलो अगला सवाल करते हैं. 17-year-old boy comes with progressive muscle weakness, weakness of the lower limbs, and difficulty in going up the stairs, difficulty in getting up from a squatting position. But then there was like death in the brother at I think at 40 years of age. In Dushnis, usually the death would be occurring by 20, 25, not in their 40s. And even the person's age group is turning out to be like 17 years of age. So considering the age of presentation and then the death in the sibling brother, I'll bet my money on this one for Becker's muscular dystrophy, that is BMD. In Dushnis, the presentation would be relatively earlier, and considering like there's a genetic basis present, so there has to be either a DMD or a BMD that has to be evaluated in this patient. Yeah, I mean 4 or 5 lines, no? Like here only, the length of the questions would be longer. We tried to do that in our TND also, like couple of questions used to be long, couple of them used to be small. So 40 was not mentioned. Okay. Okay, contractures and Emery Dreyfus. No, if they are gonna be no, autosomal dominant, right. No, this is not autosomal dominant. No, this would be X-linked recessive. No, I'm not saying autosomal dominant. I'm saying the pattern of inheritance in this would be given as X-linked recessive. That is why the boys are getting affected. But I do take your point. Like it can be Emery Dreyfus that we could be taking into consideration. I'll just keep that in my mind. With respect to Emery Dreyfus, somebody had given a comment with respect to the same. But okay, cardiac conduction defects. Okay, Nikhil, those are the interesting ones that I did not have. There are like cardiac conduction issues. So, yep. See, cardiac involvement can occur even in Duchene's and Becker's also, but that would be in the form of a cardiomyopathy and not a cardiac conduction defect. It is going to be present. And then contractures. Contractures, again, I can say, okay, so because you're saying contractures in the elbow and the contractures at the wrist of the person, so I get it, right? Why not gonna be Duchene's muscular dystrophy? Age group of the patient is little on the higher side, so I would say like if I am given to choose between Becker's versus Emery Dreyfus, and considering cardiac conduction defects are given, then I'll go with Emery Dreyfus versus Becker's. But for Duchene's, considering the age group, which is 5 years of age of presentation, most patients become wheelchair bound, no? And most of the time by the 17 years of age, very severe muscle wasting is present. So that's why like the DMD part is out. So it has to be either BMD or it has to be Emery Dreyfus. Okay, fine guys. Okay, got it. 40 may not be mentioned. That is okay. But considering like the remaining kind of data that is given in this question, if you analyze it logically, we'll try to say that A looks the least plausible option. Okay guys, the next one, I'm not sure. This is what one of my students told me, that the lips were black. Now, was it a all except question, or was it like which drug is contributing to it? The feedback I got was like the lips were black, hemorrhaging crusting of the lips. Hemorrhaging crusting of the lips was present, and considering hemorrhagic crusting of the lips, if he says what is the drug that would be responsible for it, then Steven-Johnson syndrome is gonna be caused by lamotrigine. So which drug can be, you can still use in a patient? Yeah, so he says which drug can be used. So if it is can be, which drug can be used in the patient, then it is gonna be clobazam can be used. If the language of the question is which of the following can be used, the answer is option number D. If he says which of them is most likely a cause of this presentation, then we'll go with lamotrigine. But yeah, in the face would have been darker. यार भाई अब मैं exact image कहाँ से लाऊंगा? So it's like that hemorrhagic crusting of the lips, which is a feature of Steven-Johnson. But then we don't want to expose the patient to those more aggressive anti-epileptic drugs, which can contribute to this kind of a presentation. So clobazam would make a more sense in this patient. Yeah, black Indian kid, got it. The next question deals with a patient having a upper and lower limb weakness with a slurred speech. So this is a MCA territory stroke. Was it a CT scan that was given, or was it like I mean, normally they give a CT scan, so I'm a little surprised that MRI is given. So I was little, perplexed by the fact that they mentioned a MRI, and they mentioned like both I mean, initial MRI and then a ADC. But the point is like, was an MRI given? The clinical presentation is that of a MCA territory stroke. So I would like to manage this patient with thrombolysis with LTEPLACE. Transient ischemic attack point against that. I mean, why am I ruling out even without focusing on the images? TIA usually shows an improvement, whether if TIA has to improve, no, then the improvement usually starts with the first hour in a patient. So we'll go with the full MRI with multiple limits was given. Uh, it happened in the morning. Okay, fine. So this started in the morning. Point taken. But he would still be in the incubation period, right? When the patient comes, we can do thrombolysis. And nowadays, we do both the things. Now, patient comes, we do thrombolysis, and then we take the patient up for mercy as well, because thrombolysis is going to soften the clot, and then subsequently a mechanical thrombectomy in the patient can be done. Yeah. Initial management in this patient, no? So initial management is not gonna be aspirin and clopidogrel. We don't give aspirin, clopid. We give it after 24 to 48 hours, na? Because I have to start thrombolysis in the person. So if I will give aspirin, clopidogrel, then the chances of bleeding in the brain will be dramatically increased. So we are not gonna use those A and D kind of drugs. And mannitol has, I mean, no role. It's gonna be mainly used with respect to posturing in a person and not with respect to ischemic stroke. A hypertensive bleed on a CT scan all the way. Like if it's a hypertensive bleed, then we will do lowering of the blood pressure. So I think we are mixing up two questions. One is that MRI one where multiple images on the MRI were given, and it was a case of ischemic stroke, and that's going to be thrombolysis. And the second question I think was in the radiology where or surgery. I think they mentioned that the guy had a CNS bleeding, and he said which of the following would be done in a patient. The person was hypertensive. So in that hypertensive person, if I take your point, hypertension present, and there is a CT that is showing a hemorrhagic stroke or there's a hypertensity, and he says what is first to be done, then we'll not answer mannitol for the person. Then our intervention in that case would be that we will like to use calcium channel blockers to lower the blood pressure. I think it was either nicardipine, nimodipine, or maybe nifedipine in the options, but then the point is CCBs would be used or labetalol would be used in those circumstances. So I think there are two different ones that we are mixing in a single question, but yes, the way the question is presented, the answer for this one would be thrombolysis with L-Teplis. Then is a question with respect to lithium. Now, lithium basically will be affecting the sodium potassium pumps, and the moment I talk about potassium, I mean the functioning of the potassium pumps is affected. So hypokalemia based ECG finding is what I'll be taking care of. And the common finding that I'll be getting is a T-wave inversion. I mean, the logic I'll just go with this, like if there's a hypokalemia, then the first change to occur is changes in the T-wave of the person, like arrows going down. So a T-wave inversion makes a plausible sense. And yeah, subsequently a ST segment depression would also be coming in. But like the common presentation would be the change in the polarity of the T-wave, mainly with respect to the sodium potassium pump functioning and hypokalemia based ECG findings that can be seen. Answer to the current question on the screen is alpha. Then is a COPD patient who was planned for a elective abdominal surgery, and he says like what is the best intervention to reduce pulmonary complications in a person. I was actually looking for LTOT, long-term oxygen therapy. Hit the comment button whether LTOT, long-term oxygen therapy, was in the options. If LTOT is not in the options, what are we gonna do? Obviously ask the person to quit smoking, which is physiotherapy, because I want the chest muscles to be in top shape to prevent the development of type 3 respiratory failure in a person. You are aware that any patient who is going to be operated for abdominal surgery can go into post-operative atelectasis. So that's why chest physiotherapy would make mention. And since LTOT is not in the options, so this was like a super sweet question for you guys. So another bonus question that they gave you, smoking cessation with chest physiotherapy. This is what even a non-medical can answer, right? So there would be mixed bag. Like some of them are gonna be like, oh my God, he's asking me ECG with respect to valvular lesion, and there's somewhere we just have to quit smoking, or like that inferior wall MI one also. No, the BP was low. You need to give a fluid challenge to the patient like that. Then the murmur of ventricular septal defect is that pan-systolic murmur. Maybe the framing might have been little longer of this question, but then the essence is ventricular septal defect, high pressure to low pressure shunting would cause a PSM or a pan-systolic murmur. Another ABG based question on the agenda. I think pH was hitting normal, 7.45 or little on the higher side. I'm not very sure, but what was very much present was one, PCO2 was less. That means hyperventilation will be occurring in a patient. Whenever hyperventilation will be occurring, first you look at pH, then you look at PCO2. So even if the pH is on the higher side of normal, you look at PCO2 that is lesser, that means hyperventilation, that means respiratory alkalosis. In respiratory alkalosis, bicarbonate should also begin to reduce. Just like in respiratory acidosis, bicarbonate rises. In respiratory alkalosis, bicarbonate should be falling. So that means that compensation has started. Na? Suppose in this question, bicarbonate was normal. Then I would have answered it as uncompensated respiratory alkalosis, considering the fact that bicarbonate of the patient is beginning to fall. Therefore, we'll say that the chap is suffering from a compensated respiratory alkalosis. The answer to this question is option A. I'll just take 15 seconds to explain this again. The guy is breathing faster, CO2 washout, so respiratory alkalosis. In respiratory alkalosis, check out the bicarbonate. If it is normal, uncompensated. If it's gonna be less, it's compensated. And like the basic table that I made, by default, all the values, if they satisfy the table that I have done for you, is always gonna be the compensated variety. So this is another ABG based question that we have discussed at the moment. So I mean, I don't find the rationale behind asking 4 of ABG based questions, but then it's okay. If you get one right, then the second, third, fourth are automatically gonna be right. It's just like as simple as that. ABG is just a hang that you need to have as a reflex. Okay. 35-year-old guy with fever, myalgia, redness of eyes. So standard features of like flood-based leptospirosis. And he says this presents with respect to septicemic phase. Initial leptospirosis is what is happening. Weil's disease is when there would be hemorrhage, when there would be AKI in a person. So if there was mention of like there was like the liver was failing, or there was mention of fulminant hepatic failure in a question, I would have answered it as Weil's. But at this moment, the guy is into dissemination of infection into the bloodstream, which causes this intense myalgia and the fever presentation. Okay. Hit up the comment button for this question where findings of lumbar puncture were given with lymphocytes. Now, please don't blurt out the answer as TB meningitis. I know that that's what you would have loved to answer. I'm just doing a verbal autopsy of the question. This session is like a verbal autopsy. So my question to you guys is one, what was the duration of illness in a patient? Was there some symptoms related to tuberculosis given? Was there any X-ray, some lymphadenopathy given? Please hit the comment button for a yes or a no for that. And then I would like to know from you regarding any protein information given. Like, you know, I read a comment saying cobweb. I am very unsure about it because one guy mentioned that cobweb thing, but that's I think that might have been a scattered report there. So okay, 300 milligram. Fine, guys. So this is pretty high. If not 1 gram, 300 milligrams is pretty high. There is no cobweb, there is no long history. They mentioned fever for 5 days, so that is okay. I mean, there is going to be fever, headache, and then there are going to be symptoms for 5 days. So we'll go with like lymphocytosis in an Indian exam with low CSF sugar. The CSF sugar value is turning out to be 0.4, no, 40 divided by 100 proxy. So that's less than 0.6. So we'll go with tubercular meningitis for this particular case. And in case the sugar was turning out to be normal, then I would have like, you know, been a little apprehensive answering it as TB meningitis. Then I would have said, okay, man, this can be viral meningitis as well. But since like everybody said the sugar values were lesser and the protein values are like 300 milligram, then we'll go with tubercular meningitis. And can TB meningitis present with history of 5 days? Yeah, lack of education. Right? People will come late to the hospital. They say we are sick only for 5 days. No, so I'll not go by like what the patient is saying to me. The bottom line is that patient would have been sick for a month. He did not realize that he was sick. So that's how things are gonna be. They'll just say abhi to hua hai, abhi kal se to shuruaat hui hai. So that's how the things would be presenting in our hospitals. Okay. Then is this rheumatoid arthritis patient with the lesion on the leg on the I think the lesion is beginning as a pustule. Okay, it's on the shin, it's on the pustule, it's beginning as a pustule, then evolves into a S-char. So initially I thought he's trying to ask me about some kind of a infection based presentation. But then if you look at it, the guy could be on medication as well. He's having rheumatoid arthritis. So these patients could be having an immunologically mediated ulcer on the shin. Now, only time you read about an ulcer on the shin of a person is pyoderma gangrenosum. Ecthyma gangrenosum also is black in color. It has a S-char, but that's going to be seen mainly with respect to pseudomonas in a patient. And necrotizing fasciitis is what you see with febrile neutropenia. So considering that word like immunomodulatory disorder, like traditionally we read pyoderma gangrenosum with IBD, inflammatory bowel disease, especially ulcerative colitis and Crohn's. But then the point is, can be seen with rheumatoid arthritis as well. The main keyword for this question, the pickup point would have been the ulcer on the shin of the patient. Cutaneous TB presents on the face and on the buttocks. The cutaneous tuberculosis manifestations, one could be face and neck, no, because they could be scrofulloderma, or like on the face the lesions could be there, or on the buttocks the lesions could be there. But pyoderma gangrenosum is a lesion on the shin of the person. Then for this question again, some people said it was an anatomy based question. They asked the artery which is marked, which is the left anterior descending artery, and some people said no, it was the surface of the heart getting involved present. So I think it can be both treated as medicine slash anatomy based question. And the blood vessel that is marked here is one of the main blood vessels, that is the LAD, the left anterior descending artery, which is also called as the anterior interventricular artery. So I'll go with like widow's artery, LAD, whatever the name given, LAD, interventricular artery, anterior interventricular artery. And the surface that would be involved here would be with respect to the commonest type of MI, that is anterior wall myocardial infarction. Just if I shift the position of the arrow a little more laterally, then it becomes left circumflex, and the lateral wall of the heart would then become an answer. But unlikely, in my opinion, like they'll ask you common things. Common thing is anterior wall myocardial infarction slash interventricular artery, whatever was there. I mean, it would have been interventricular, LAD, anterior surface. Ultimately, the gist is that the anterior surface of the heart gets involved. Okay, a hot favorite that comes up is Zenker diverticulum, and then he says which muscles would be involved with respect to this one. So this would be thylopharyngeus and cricopharyngeus muscles. Are drawn line diagrams for the same as well. So at this moment, guys, these are a couple of those where I could complete all the 4 options. The correct answer for this one is option number A. And there are a couple of others also where like we have like maybe 1 or 2 options. So we will be like, working on those options subsequently. And once we have those all the 4 options correct with the wordings and framings, then subsequently like it makes sense to discuss them, or like put them out on the app. So it was once again nice interacting with you guys. These are a couple of those bunch of questions where like I can say it's not an exact framing, but we try to do as much as possible. I obviously can't produce a black Indian kid image, right? If I mean that obviously can't be replicated. So but then those words that I mentioned, sausage, pancreas, or a couple of other things are the ones which if you are gonna just analyze them, you would be on your way to glory. So my best wishes for a great result, guys. I mean, these days would not come back. Spend some time back at home. I mean, you guys have been abroad for so many years, away in the chilling winters. Now you get an opportunity to interact with your loved ones in India back home. So sit back, relax, and enjoy these days. They won't come back. And then the internship is going to be crazy in India. It's going to be very hectic. The workload is tremendous. And now would be the time to learn practical. Like you learn the theory part good now, but now is the time to learn the practical ones. So with these words, I finish my discussion for today. Thank you so much for your joining in and your inputs. And yep, we will be incorporating your suggestions in the final version in the app. Take care, guys. God bless you. Nikhil, if there was a liver and a renal failure, no, then we change it to Weil's disease. The input I got was no liver and renal failure. Then I'll say it is the septicemic phase. But yeah, it would be Weil's icterohemorrhagic manifestations there. So thank you, guys. Yeah, okay. It could be a barium. It could be an MRI in a person. That's perfectly fine as long as the gist of the question is satisfied. Yes, guys. Fine. Take care, guys. Bye bye. God bless you.